Anyone?
It's a feeling of intense sadness.
Okay.
Yeah, excessive stress, like during this month of exams.
Yep. Yeah, so depression is basically you're having persistent feeling of sadness, and ideally you don't have you're not interested in anything per se. You don't want to socialize, you're just in a low mood. Anything else? Something else you can add on?
You might even have suicidal thoughts, not only feeling sad.
Yeah, suicidal thoughts are associated with depression. Yeah, it's sad to see that we're losing some people to this silent killer. Something else? Who are mostly affected by depression? Would you
Women,
say?
I think.
Okay.
Women.
Women. Is there a particular age you'd expect, and is there a particular age bracket you'd expect to have, to be more prone to having depression?
I don't think it's necessarily linked to age, because anyone can have depression regardless of their age.
Mm-hmm.
Plus, I think people who have other psychiatric disorders like anxiety, substance abuse, are more prone to depression than others.
Yeah.
And, yeah.
Okay. What do you think what are some of the causes of depression? What triggers someone to be depressed? When you hear someone saying, I'm feeling depressed, what do you think has caused them to feel depressed?
Could it be an imbalance of the neurotransmitters?
Yeah,
And the
that's
system.
okay.
And also amount levels imbalance.
Okay, we can say some among the pathophysiology of depression, we have various hypotheses that have been associated with someone having depression, and its dysregulation of hormones. These are things like neurotransmitters. Yeah. Something else, when you have a deficit of maybe norepinephrine and the dopamine and the serotonin, like, sorry? Shafi, you were saying something?
No.
Oh, okay. So something else about depression, other than someone having low hormones, what else can cause depression? What are the other things can trigger depression? Could there be genetics involved?
Drug abuse.
Okay. Yeah, genetics is actually involved in depression. Anything else? Something else? Can you see my screen?
Yeah.
Okay. So these are just Dr. Amsalu's notes. just want us to have a discussion like we've been having. I'm not necessarily here to take you through all the 47 slides. So it will help if you engage a little because we have 2 more topics to cover. So something else that can cause depression. Okay, when someone is also stressed, stress can trigger depression. I'm sure I think you all know that. So let's go to the clinical presentations of depression. What are the symptoms one should look out for? Like clinically speaking, what do we look out for in order to diagnose someone with depression, and how long would you say these symptoms should last before diagnosing this person with depression?
Some of the symptoms are emotional symptoms like feeling sadness, you're feeling emptiness, anxiety, worthlessness, having thoughts of suicidal thoughts. Also, there are some physical symptoms like there's change of appetite, decreased energy, you feel fatigue, and then even sleep. I think there's disturbance in the sleep. I'm not sure of that. Yeah.
Yeah, true. Yeah, so ideally, some of the symptoms we can use to diagnose someone with depression, we have things like you're depressed, you're always in a depressive mode, you're either lacking sleep or you're sleeping too much. This person is either having either high appetite or low appetite. They also decrease in the usual activities they normally do, and also I feel like this is the key symptoms, which is the key symptom, which is suicidal thoughts. And how long should this person have these symptoms in order for you to say that they are diagnosed, they are depressed? Any idea?
2 weeks.
Yeah, it's a minimum period of 2 weeks. If they have is it? I'm not sure how many symptoms they have. Let me confirm from the notes.
At least 5.
Yeah, so as you can see, these are the presentations: disturbed sleep, decreased energy, fatigue. Yeah, everything that we've just mentioned. So as you can see from the slides, the symptoms should be there for a minimum of 2 weeks, and also the person should have at least some of these symptoms. You've said 5.
Yeah, it's even in the
It's even in the slides. Yeah, at least 5 of these symptoms they should be presented from the patient in order for you to clinically diagnose them as depressed. Okay, so let's go to where we play a role as pharmacists. So what are some of the pharmacological drug ways in which we treat depression? Or let's start with the non-pharmacological first. How would you non-pharmacologically handle a depressed person? Anyone?
Cognitive and behavioral therapy.
Therapy. Yeah, therapy actually
Therapy
really.
is the most important here because you talk to the patient,
Yeah.
you hear them out what they're going to say. Someone said that, can you hear? Or can you guys hear? Yes, we can hear.
Oh, someone is having trouble. Yeah.
Yeah, and then there is
Yeah. Like Shafi said, therapy is the most I would say effective non-pharmacological way what are the most common used non-pharmacological method for handling depression? Other things, I'm not sure if they're really used that much. Could be things like was CBT being used? I'm not sure. There is electroconvulsive therapy. Yeah, such like things. But let's take let our takeaway message be therapy. So on to the pharmacologic treatments. What are some of these classes of drugs, the examples of these drugs, the adverse effects? Someone at least to pick a class of these antidepressants and tell us something small, their mode of action, side effects, yeah, something like that. So, anyone? What are some of these classes of antidepressants? I'm sure we all know them, or you're at least familiar with a class or two.
SSRI,
Sorry?
SSRIs.
Yeah, there are SSRIs, which are the serotonin.
Yeah, they inhibit the reuptake of serotonin.
Selective serotonin reuptake
Yeah, selective serotonin reuptake inhibitors. What are some of the, or what is the mode of action of these selective serotonin reuptake inhibitors?
I think from the name, they just inhibit the reuptake of serotonin.
Okay.
So they'll increase their levels in the synapse.
Yeah.
And they're the first line, I think.
Yeah, they're actually the first line. That's a really key point. So SSRI is the mode of action, like Black Panther has said. Yeah, they'll increase the serotonin levels. This is by inhibiting their reuptake. So there will be more serotonin in the presynaptic neuron, and they're also the first line. Some of the examples of drugs in these classes, anyone?
Loxetine.
Yeah, Corazon is saying Fluoxetine, even Black Panther. Something else. Yes, citalopram. We also have paroxetine. Sorry?
sertraline.
Oh, sertraline. Yeah, sertraline is also there. And some of the side effects of the named drugs. What do you think some of the side effects could be?
Sexual dysfunction.
Yeah, actually one major side effect for these drugs was sexual dysfunction. How would you handle someone who has come to you complaining of sexual dysfunction as a side effect of these drugs? Corazon is also saying GI disturbance. Yes. Yeah. So how would you handle this sexual dysfunction from the patient, or rather to the patient?
You switch to another antidepressant.
Yeah, you can switch antidepressants. You can also give maybe an adjunctive therapy. You
And
can
reduce the dose.
Yeah, you can reduce the dosage, or you can just tell the patient to wait it out. Maybe the symptoms could subside. Anything else I've left out on SSRIs? Someone can add something before we move to the next class of drugs. Is there something else I'm missing out, or you feel like or something you have to add? Oh, adjunctive therapy. Sony is asking the adjunctive therapy.
And then if you give this SSRIs to the patient, when you want to discontinue, you're supposed to taper the doses to prevent the syndrome. It's called something syndrome, serotonin syndrome.
Oh yeah, there was something like serotonin syndrome. Yeah, so you taper off the drugs if you decide to discontinue the chosen antidepressants. So to answer Sonia, the adjunctive therapy could include things like the dopaminergic drugs. You can also use things like serotonin antagonists, things like cyproheptadine. Yeah. Also, we have the common phosphodiesterase inhibitors, things like sildenafil. I think sildenafil would work because I think we all know how it works. Yeah. So Sonia, are you okay? Have I answered you well enough?
Okay, something else is that fluoxetine also has a significantly longer half-life than the other one.
Sorry?
Fluoxetine,
Okay.
yeah, has a significantly longer half-life.
Yeah. So the fluoxetine actually has a long half-life. You should also remember that. Corazon is also saying some of the side effects for nausea induced by the drug, you can give ondansetron. Yeah, that's true. Something else, you had mentioned the other classes of drugs. Let's go to TCAs. What do you know about TCAs? Anyone? The tricyclic antidepressants. What are some of the examples of drugs that are TCAs? Black Panther.
Amitriptyline. Yeah, amitriptyline, doxepin.
Yeah, amitriptyline. Yeah, such like drug. Clomipramine. Was clomipramine there? I'm not.
Yeah, clopidogrel. Yeah.
Yeah, it was there. Any other drug? Also, Corazon was asking something. Let me go back to the question. She's asking what was the target center by ondansetron.
What is the target of?
What? Sorry. What? She's asking what? In short, the chemoreceptor triggers on. What receptor, or rather, what part was being targeted by ondansetron? It is the head.
So it's 5-HT antagonist.
Yeah, and it's in the brain.
Is she asking how it reduces the nausea, Amma?
No, it's just asking which particular part was the drug acting on, like the 5-HT3, but where particularly, which is the CTZ.
Chemo shifting.
Yeah, the chemoreceptor triggers on. Yeah. So I hope we've answered that. So imipramine is also another type. Stanoa said that. Yeah, so also Divya is saying that TCAs inhibit the serotonin and norepinephrine reuptake. Let me finish what she was saying. Okay, I can't see Divya's message again. Okay. Anyone in the chat box, can someone read? Okay, well.
Inhibits
and norepinephrine reuptake within the presynaptic terminals. Yeah, that is the mode of action of TCAs. Some of the side effects of TCAs. What do you know about TCAs?
TCS can have. It can also inhibit muscarinic and adrenergic receptors and histaminic receptors, and it can lead to anticholinergic side effects like sedation, hypotension.
Yeah, that's true. It was causing serious anticholinergic effects. These are things like someone having dry mouth. Such any anticholinergic symptom you can think of, it was causing that. Also, Black Panther was is saying about sedative because of the histamine aspect. Yeah, drowsiness, blood vision, all these will be associated with the blood vision will be associated with what with the with anticholinergic effect. Also, orthostasis, Liz is saying orthostasis. Could you kindly explain what orthostasis is kindly? Honestly, I don't know. Any other side effects? Or who knows what orthostasis is? Oh yeah, it was hypotension on yeah. Thank you, Liz. Yeah, are we done with TCAs? Have we covered everything? What is there to be added to the drugs? Something am I missing something, or who wants to add something about TCAs? If there's nothing, let's go to the other class of drugs, which was the the Mao. Who can tell me some of the examples of these drugs?
Sertraline.
Yeah, the things like selegiline, something else, another drug. There was also phenelzine. Stanley is saying tranylcypromine. There's also carboxazid, phenelzine, selegiline, and the one that is hard to pronounce. Yeah, so all those are examples of the MAO inhibitors. Who can tell me the mode of action? How do these drugs help with depression? What do they do?
MAO inhibitors, they block the monoamine oxidase.
Yeah. So they'll
enzyme both inhibits them, and it will increase the norepinephrine and serotonin in pre-synaptic cleft, and then it will improve the
yeah. So
depressive mood disorders.
Yeah. So ideally, the mode of action is they inhibit the monoamine oxidase. What does this monoamine oxidase do? It is the one which is responsible for breaking down the serotonin, norepinephrine, and the dopamine. So in short, when you inhibit this enzyme, you'll have more levels of these hormones, hence will help. So Black Panda is saying we talk about the two forms of monoamine oxidases. Who can tell me how many they are, or rather the two forms that we have and where they are mostly found in the body? Who remembers?
Okay, we have MAO A and MAO B.
Okay.
MAO A mainly found in the peripheral adrenergic nerve endings, also in the intestinal mucosa, the placenta, and the liver. And then MAO A mainly deaminates serotonin, noradrenaline, and dopamine. And then MAO B mainly found in the brain, mostly the basal ganglia, and also the platelets and the liver, but mostly in the brain. And then deaminates mainly dopamine. Yeah.
Yeah. So sorry. Shafi was trying to say something. Okay, you've
Yes,
said,
Brenda.
oh, are you trying to say something? So you've said,
No.
yeah. Kindly repeat. You've said MAO A is mostly for which hormone and MAO B was for which hormone? Okay, I haven't gotten that.
Okay. MAO-A mainly dominates serotonin, dopamine, and noradrenaline. Yeah, then MAO-B mainly dominates dopamine.
Yeah, mostly dopamine. Okay. I hope everyone else here amesikia. I hadn't really gotten that. So when you're giving someone these MAO inhibitors, what side effect would you expect? What patient advice can you give them? Should they be avoiding something? Yeah. Also, Abdul Malik is reminding us that selegiline is particularly selective for MAO-B, but if I can recall correctly, phenelzine was non-selective. So it's good we also remember that. So phenelzine is non-selective, selegiline is purely for MAO-B, the monooxidase inhibitor. Side effects for these drugs, what do we tell patients? Div is asking, is this the group of drugs that have withdrawal effects? Personally, I'm not sure, someone else can answer. Does it have any withdrawal effects? Or in short, what effects does it have? Does the drug have?
I think it's that one where you're supposed to restrict your diet. You cannot eat food with like cheese or drink wine if you're taking monoamine oxidase. Like I think it's that one.
Yeah, true. So the thing with these MAOs in these monoamine oxidases, you need to tell your patient to there's some dietary restrictions that you have to tell them. That means that is they have to avoid the tyramine rich foods. Who can tell me why specifically tyramine foods? What do these tyramine foods do? When you take
Because when you take MAO inhibitors, they inhibit the degradation of these tyramines. So they can result in drastic increase in blood pressure, which can lead to stroke and myocardial infarction. As in tyramine is synthesized by MAO, monoamine oxidase.
Kama amepotea kidogo. Fatma,
Can
you
you
still
hear me now?
Yeah, we can hear you.
I think it's my internet. Tyramine is metabolized by monoamine oxidase.
Yeah.
So it will lead to increase of norepinephrine and decrease metabolism of tyramine containing food. So when you give monoamine oxidase inhibitors, they will inhibit the degradation of thiamine. So which means it will increase the blood pressure and it can lead to stroke and myocardial infarction because they are metabolized by the same enzyme, MAO, I mean.
Yeah. And what you should remember is, as Scooby-Doo has said, these dietary restrictions are are for the MAO-A inhibitors specifically.
Selective.
Yeah. So even Abdul Malik is also saying the tyramine is inactivated by MAO. It causes release of catecholamines from the nerve endings, resulting in hypertensive crisis. Yeah. So ideally, these drugs will cause hypertensive crisis if you take them with these tyramine-rich foods, which include cheese, yogurts, things like even beer, chocolate, yeah, such foods. Have we exhausted everything on MAO inhibitors? So we can go to the next class of drugs. Or does someone have anything to add on to what we've said? Okay, so let's go to the other class of drugs, the serotonin norepinephrine reuptake inhibitors, the SNRIs. What are some of the examples of these drugs? Yeah, you know the drill by now, so tuongee. Yeah, Blackman is saying one example is duloxetine. Most people confuse the duloxetine and fluoxetine. So fluoxetine, remember, is an SSRI. Duloxetine is the one that is an SNRI. Yeah, so let's not confuse those two. Something else? There's Stanley saying there's venlafaxine and venlafaxine. Yes. Those are also examples of SNRIs. Okay, Abdul Malik, I think this has to do with the MAOs. He's saying phentolamine and prazosin are helpful in management of tyramine-induced hypertension. Oh, thank you so much. Personally, I didn't know that. Thank you. Something else about SNRIs. What's their mode of action? So Corazon is saying duloxetine is in patients with history of heavy alcohol is contraindicated. Is that it? Yeah, in patients with history of heavy alcohol intake or chronic liver disease, since it can cause hepatic injury. Yes, thank you, Corazon, for that. So what's their mode of action? Yeah, Blackman is saying they inhibit the serotonin and norepinephrine reuptake inhibition. So just like SSRIs, they will increase the levels of these neurotransmitters. Yes. Something else to add on to these SNRIs? Are there any other drugs used for antidepressant, for depression, other than the classes we mentioned? So we've talked about SSRIs, we've talked about the monoamine oxidase inhibitors, we've talked about the TCAs, talked about the SNRIs. Yeah, so other drugs which can be used, which are atypical in nature, you can say these ones, the trazolopyridines, the likes of trazodone. Yeah, I'm not sure if they are normally used as such. They'll also inhibit the the reuptake of these hormones.
Serotonin.
Yeah, the serotonin. We also have bupropion. It will also inhibit the reuptake of norepinephrine and dopamine. We have so as you can see, the major side effect of this bupropion is seizures. Yeah. So there are a class of antidepressant is mirtazapine. You can see the mode of action is that it blocks histamine receptors, and it also works on the adrenergic.
Adrenergic and serotonin receptors.
Yes.
And then mirtazapine, it has low risk of sexual dysfunction as compared to SSRIs.
Yeah. So when you were saying you can switch to another class
I think
sorry?
mirtazapine, trazodone, they are all atypical psychotic, I think.
Yeah, it's an
They're
atypical.
atypical. Yeah.
So
I think they can also be used as a monotherapy, if I'm not wrong.
oh, okay. That's good to know. Okay.
How
I feel
about
like
lithium?
how about
How about lithium?
sorry?
Lithium.
Oh, lithium.
Yeah.
Do you
Used
use
in depression that's resistant depression. That's treatment resistant depression.
oh, okay. I think I didn't know that as well. So depression is which is resistant.
Which is resistant to other treatments.
Yeah.
Lithium.
Okay. So I think we've covered most of the drugs, or rather things we need to know about major depressive disorder. Unless there's anything to add, someone can just add, and then you can go to the next disorder. Is there something I have not mentioned, or is anyone wants to add something want to? Oh, let me check the messages. Black Panda was asking propion. Yeah. Sorry.
Alafu I can see.
Yes,
Can you
Rafi?
guys hear me?
Yeah.
I can see in Dr. Erimi's notes, there's also serotonin, dopamine activity modulators like aripiprazole. They act as a partial agonist for serotonin and dopamine receptors.
Okay. So those are serotonin. You said serotonin? Shafi. Okay. I can't hear her correctly. So Black Panda is asking, how do we manage? What are the safest drugs to use in pregnancy for depression? Which are the safest drugs for depression in pregnancy and lactating mothers as well? I think, Belinda has answered, fluoxetine. I think generally SSRIs are safe in pregnancy and also lactating mothers. So if a question would come, which is the safest for a pregnant woman? If there's an SSRI among the options, that would be the best. That would be the best answer. Yeah, even Corazon is also saying, yeah, for lactating women, SSRIs are also safe. Yeah, for both populations, SSRIs is safe. Remember, we also said that the first line management for MDD. If there's nothing else to add, maybe we can proceed to Parkinsonism. If you all agree, we can move to the next topic, or if there's nothing else to add. Okay, TV is saying sure. Okay. Paroxetine, or specifically causes cardiac abnormalities, so not safe. Thinking not safe for pregnant women. Is that it? Yeah. So, okay, fluoxetine specifically, let's not generalize it as SSRIs. Let's just say fluoxetine is safe for pregnancy and lactation. Yeah, sorry about that. Yeah, thank you guys for that. If there's nothing else to add or subtract, we can proceed to Parkinsonism. Okay. So before again, I display the notes. What do you guys know about Parkinsonism? Anything at all about Parkinsonism? What is Parkinsonism? How does it happen? Yeah. Anyone? Yeah, so Divya is saying we have four main features. There are tremors, slow movements, impaired balance, muscle stiffness. Yes, all the symptoms are associated with Parkinsonism. Belinda has also emphasized on the symptoms, the tremors, the rigidity, akinesia, and postural instability. Yeah. Also, Divya is saying it is caused due to low dopamine levels. Yes, that's also true. Anything else, something else, however small, however big. Anything about Parkinsonism? The Lewy bodies, I'm not sure, or rather, what do the Lewy bodies do? How are they associated with Parkinsonism?
Okay, from like the molecular aspect of how Parkinsonism is caused, they're like these Lewy bodies, and they're protein, so they form aggregates, and then they polymerize in some sort of way, forming these alpha helical conformations and the beta sheets. Now, I think these protein aggregates are the ones that damage the dopaminergic neurons. Yeah.
Yeah. So, continue.
Yeah, so that now we have like an increase in the activity of dopaminergic and then a decrease in the cholinergic. Like there's no balance.
Yeah, that's true. That's true.
Okay.
Sorry?
Can you hear me?
Yeah.
Parkinsonism disease is a dopamine neurons that are neurodegenerative disease that affects dopamine neuron in the substantia nigra, and then it causes the disruption in the ability to generate the body movements. So the person may have impaired body movement.
Yeah. So yeah, in the pathophysiology of Parkinsonism, you need to remember that it's a neurodegenerative disease and there are motor symptoms associated with it. And you can say that it mostly affects males. So we can say one of the risk factors, we can say gender, even age. Age is also particularly associated with Parkinsonism. Something else, any other risk factor? I want us to have flow before we go to the pathophysiology aspect of it. So some of the risk factors of Parkinsonism, what do you guys think are some of them? It seems I don't have the notes for Dr. Msalu on this particular topic. So anyone who has the notes, can you kindly display or share the screen if you can get a hold of Dr. Msalu's notes? I didn't realize I don't have them. So what do you guys
see the screen?
Yeah, you can see it.
Yeah. Those are the notes of Dr. Msalu.
Okay. So before we go to the pathophysiology, some of the risk factors, I think Stevie had typed something. Genetics, yeah, that's true. From Black Panda. Age,
Okay.
yeah, true, from Scooby-Doo also. Exposure to heavy metals, yeah, that's also another risk factor. I think from Dr. Msalu's notes, he stated that aging is the primary risk factor of Parkinsonism. Yeah, so I think we can go to the...
It disappeared, right?
Sorry?
My screen disappeared, right? I don't know why.
Yeah.
I don't know why.
It's okay.
Can you see it?
Yeah, now you can see it. You can see the screen. Okay, yeah, the mnemonic trap can be used for the symptoms. Trap meaning there is tremors, which is also known as the pill rolling. I think you can get a picture of someone rolling a pill. R stands for rigidity. This is mostly called the cogwheel movement, where I don't know if some of you have seen some of these patients in Matare. You can see some of them, how they walk in, I don't know, maybe someone can get a picture of how cogwheel movement looks like. A standing for akinesia and P standing for postural instability. Yes, thank you for that, Scooby-Doo. So those are the hallmark symptoms of the motor symptoms of Parkinsonism. Thank you, Scooby-Doo, for that. So something else about the pathophysiology of Parkinsonism. We've said that it is due to loss of dopaminergic neurons, and there's also an imbalance between the serotonin and the dopamine. So this will cause these uncontrolled muscle movements or uncoordinated muscle muscle movements. Is there something else I'm missing? Or if someone can better explain the pathophysiology, please, the floor is yours. No, was it serotonin really? Sorry, no, it was acetylcholine, not serotonin. I'm sorry about that. Is there anyone who is in a position to better explain the pathophysiology of Parkinsonism? Anyone who still remembers how Dr. Amy has emphasized on its pathophysiology in class, to just explain it?
There are two pathways, the direct pathway and the indirect pathway. I don't think I can remember so well. But the indirect pathway, it was coming from the striatum, and then there was a direct inhibition of D1 and D2. The direct pathway, it's inhibition of D1, which will inhibit, it will form an inhibitory signal to the medial, I don't remember so well, but I think guys can help us.
Guys who've been chosen to take us through pathophysiology. Okay. He says he has unstable internet, so he can't be heard. Okay. I don't know if I can try to remember. Anyone who has any vague explanation of this, please, utakuwa umetusaidia. Just speak up. Okay.
I don't know if my internet has stabilized. Am I being heard clearly now?
Yes, yes.
Well, I do. Can't say I remember it very well, but you'll allow me to just jog my memory by us quickly going through the theory part before us coming to this image, kindly.
Okay, that's okay.
So,
Guys,
yeah.
I think it starts from the cerebral cortex, which send excitatory glutamate to the striatum. So when the striatum is activated, it sends excitatory receptor to G1 to D1 and inhibitory receptor to D2. So the D1 is the direct pathway, the D2 is the indirect pathway.
Yeah, that's true. That's true.
Yeah, that's where it starts. But I don't know from there what happens.
I remember for D1, I think it facilitates intended movement. So when you inhibit that, you'll have unintended movement. Then for D2, it's supposed to inhibit unintended movement, and then it does vice versa. Okay.
It was something like that. So Shafia said, or guys, are you still trying to explain Your Wi-Fi is still
No,
unstable.
I think it's been explained, and given the nature of the exams being MCQs, I don't think such much detail can really be tested.
Okay, so let's go to the diagnosis of this Parkinsonism. What is the criteria for diagnosing Parkinsonism? Okay, so I think from my notes is that we have the presence of at least one of the three features, the three key symptoms that we mentioned earlier, the rigidity, the tremors, the akinesia. Yeah, at least three of them, and that way you can diagnose someone. So let's go to management. What is the first line for Parkinsonism disease, and how do these first line drugs work? I'm sure we've gone through some of these past papers, so I think it will be just a walkover through these drugs. So who can tell me about the first line drugs for for Parkinsonism? So someone has typed, let me see who it is.
Levodopa.
Yeah, first line is levodopa, and levodopa is always given with carbidopa. We have the COMT inhibitors, the likes of entacapone, and tolcapone. We have anticholinergic drugs such as benzotropine. You also have MAOs. Yeah, Div is asking why are levodopa and carbidopa given together?
Because in levodopa, there is peripheral conversion of levodopa to dopa. So when you give it with carbidopa, it inhibits the enzyme that will form the peripheral conversion of levodopa to dopa.
Yeah. So, she's asking, is it synergistic? Oh, yeah, we've been told it's potentiation. Yeah, so carbidopa, levodopa, I think we won't dwell so much on that. We've covered that a lot. Also, Belinda is saying above 70 years, we give levodopa and carbidopa. Below 70 years, we give dopamine agonists, such as bromocriptine. Do you have any side effects for carbidopa and levodopa? Is there any side effects you need to look out for? Or any patient advice? Anything regarding carbidopa and levodopa as we move to the next class? So Abdul Malik is saying carbidopa inhibits aromatic L-amino acid decarboxylase in the periphery. Yeah, that's true. So any side effects for levodopa and carbidopa?
Could you talk about the wearing off and on and off phenomenon of levodopa?
Yeah. Also coming to that. Yeah, that is what I was trying to get. So we have some motor complications of levodopa. Which are some of these complications of levodopa? Like you've mentioned, we have the wearing off effects. So what happens is that who can tell us what happens in this wearing off effect of levodopa and carbidopa? And how can we help someone who has this?
Okay. So for the wearing off, it's when like initially the dose will improve mobility and all that, but then as the drug wears off or as it's excreted or when the patient approaches the next dosing time, then this rigidity and dyskinesia appear now rapidly. So how to handle that is to increase the dose and the frequency of administration.
Yeah, that's true. That's true. What is another complication of levodopa?
For the on and off,
Mm-hmm.
it's now this happens usually in the later stages of Parkinson's disease. And then now the patients, their stages, now these are the on stages where the patient will benefit. Then the off stages when the patient will now be experiencing this dyskinesias is even when levodopa concentration is high in plasma. And then the rescue drug is apomorphine.
Yes, apomorphine was being used actually for this particular complication. Also remember the delayed was due to delayed gastric emptying or reduced absorption of the drugs. The other complication was freezing. This is where we have a sudden episodic akinesia, and there will be increased falls. There'll be a difficulty in initiating steps or rather movements. An intervention will be giving dopamine agonist or MAO inhibitor. We can also increase the dose. The other complication of levodopa was the peak dose dyskinesia. This is where now we have too much movements of the involuntary movement involving the neck, trunk, and other extremities. And the intervention would be now you reduce the doses. It's the opposite of what we had just mentioned. So any other side effects of levodopa and carbidopa? Or we can move to the next class of drugs, which something else we can add.
Does it cause brownish discoloration of saliva, urine, vaginal secretion?
I'm not sure. Can someone answer the question? I've lost that. I'm trying to look for the message. I was just seeing. So I think Stanley is saying. He's saying on that note also another combination, imipenem and cilastatin, because imipenem is rapidly inactivated by renal dehydropeptidase, so cilastatin acts as renal DHP inhibitor, has increasing the half-life of imipenem. I think she was trying to answer Divya's questions from the previous one. Okay, also something about urine discoloration. Can you go to the other next class of drugs?
One of the interactions is pyridoxine, vitamin B6. It's not given at all with levodopa because it increases the peripheral breakdown of levodopa and it will diminish the whole effectiveness.
Okay. Thank you for that. So can we go to the COMT inhibitors? Who can give me some of the examples and the side effects of these drugs? If you're saying entacapone is an example, the other example,
Tolcapone.
Tolcapone, what's the mode of action? Mm, can someone tell us the mode of action?
I think they inhibit peripheral metabolism of levodopa and making it more levodopa available for transport and can be taken to the brain.
Yeah, so actually given they're used as adjunct with the carbidopa and levodopa. They're not normally used alone. So one of the toxicities or a major toxicities, for each of these drugs.
The orange discoloration urine is for this drug.
Which one in particular between the two?
I think tolcapone.
Yeah, so tolcapone will cause a brown orangish discoloration of the urine. It will also cause some level of it's not some level. It will also cause liver toxicity. Who can tell me the side effects of entacapone?
I think the reason why tolcapone causes orange urine and hepatotoxicity is because tolcapone inhibits both the peripheral and the central COMT. And then entacapone, it only inhibits peripheral COMT.
Yeah, but that was another difference between the two. Any other side effects for entacapone? So tolcapone, we talked about hepatotoxicity, and entacapone, was it? I can't remember really. Can someone just remind me kindly? Okay, mtu atakumbuka, they will just type in the group. So going on to the other class of drugs of Parkinsonism, that would be amantadine. Anyone who can tell me the mode of action of amantadine? So someone is saying bromocriptine should be avoided in patients with pulmonary fibrosis. Also, some is saying COMT inhibitor inhibit the breakdown of dopamine itself, not levodopa. Thank you. Yeah. Anyone who can tell me the mode of action of amantadine? Some is saying the mode of action is not really understood. Yeah, but it's a drug that is used for Parkinsonism. So anyone who has something to add about any other class of drugs? Because I feel like most of some of them we've gone through them. Is a text from
Have we talked about the dopamine agonists?
dopamine agonist. Okay. Who can tell me their mode of action and example of drugs?
They directly stimulate the postsynaptic dopamine receptors.
Yes, and an example is bromocriptine.
Bromocriptine.
We have pramipexole. We also have was it apomorphine?
Apomorphine is one of them.
Okay. So is there any ADR for these drugs? Or some is also telling us amantadine is also used in neuroaminodase inhibitor used in influenza. Sorry. Thank you, Sam. Is there any side effects you need to look out for from the dopamine agonists, the bromocriptines? And do they specifically bind which dopamine receptor does it specifically bind to?
Bromocriptine is a D2 agonist. I think they're D2 agonists.
Yeah, they're D2 agonists. So if there's nothing else to add, because I think we already covered the MAO inhibitors, the MAO-B inhibitors, I think we can move on, or if there's nothing to add, tuendelee na Alzheimer's. We can go for a tiny break and then we continue with Alzheimer's. Is that okay? Neurodegenerative disease, which normally worsens over time. So you can say that it is characterized by there's a progressive decline in the cognitive aspects of an individual. These include memory loss, you're somehow disoriented. So can someone else tell me something about or rather a bit of introduction about Alzheimer's? What causes it? What are some of the risk factors? What happens for someone to have Alzheimer's?
So like in levodopa, we had the Lewy bodies. In Alzheimer's, we have now the increased production and accumulation of the beta amyloid protein now that leads to now cell death.
Yeah, true. In in Alzheimer's, we have accumulation of the beta amyloid proteins in the brain. And this contributes to the decline in the normal function of, or rather the neuronal function of the person. So Black Panther is also talking about, was it age? Yeah, some of the risk factors. There was age, I think genetics, age, genetics, something else. Also, Corazon is talking about vascular risk factors such as DM. Yeah, that's true. Also, Alzheimer's disease is the most common form of dementia. Yeah, remember there are other types of dementia. So Alzheimer's is the most common type. Something else? Anything else? Anything else?
I think in Alzheimer's, the NMDA, that's N-methyl D-acetate, is less than normal because, and then it leads to activation of unregulated glutamate signaling, because as we know, glutamate is the excitatory neurotransmitter that's involved in memory and learning. And then people who have Alzheimer's, they have issue with memory. So the issue is memory is due to this receptor. Something to do with this receptor, I think.
Yeah, true. Also remember, a common symptom for Alzheimer's would be difficulty in remembering recent events. And we've mentioned some of the risk factors such as the genetics, the family history, the DM. Yeah, also high cholesterol is also implicated in Alzheimer's. So somehow females are the ones who are mostly affected by dementia. So just a side note. For the pathophysiology, we've mentioned about the proteins. Malik is saying aka senile dementia of the Alzheimer's type. Okay, thank you. So something else about Alzheimer's. Are there some things, some tests you can do to find out if someone has Alzheimer's? Or rather, what are the symptoms other than forgetting recent events? What are some of the other symptoms that can be associated with dementia? Okay, so remember there are the cognitive symptoms and the non-cognitive symptoms. The cognitive, we've said, is the memory loss, thinking capacity is beat down, there's disorientation of time and place. The non-cognitive will include the mood changes, changing personality and such like things. Yeah, and functional, remember this person was also, yeah, thanks Corazon. Yeah, this person will also not remember performing some of the usual tasks they used to perform with ease. So according to the DSM-5 criteria, we should have at least one or more of these cognitive symptoms, yeah, in order for you to be diagnosed with dementia Alzheimer's, sorry. Something else about Alzheimer's that you could remind us of?
You said women are high risk of Alzheimer's, right?
Yeah.
But I think there are women who are post-menopausal women, because estrogen has an effect in blocking beta amyloid protein production and can even trigger the regrowth of nerve if there's nerve degeneration.
Yeah, true. Yeah, you can see it's post-menopausal women. Yes. So something else, anything else that can be added? Yeah, so remember, ideally, there is a loss of cholinergic neurons in the hippocampus, and that's why we'll have short-term memory loss, and hence you'll have a decline in memory. So someone is saying also saw somewhere that female gender is a risk factor because women tend to live longer than men, and age as a risk factor. Watu wanna grow old with you hapa ni wapi? Thank you. So women, we've talked about women, we've talked about the causes, rather the risk factors of Alzheimer's. The pathophysiology, we've also mentioned something about cholinergic sorry. Okay. So I think trended to the management of Alzheimer's. Let's just go straight to the pharmacologic drugs because that's where we want to get the knowledge from. So what are some of the categories of drugs that are used for Alzheimer's? Any class of drugs that are used for. Diva is talking about cholinesterase inhibitors like donepezil. Yes. Corazon is saying cholinesterase inhibitors too.
NMDA antagonists.
Yes, NMDA antagonists such
like
as
memantine.
Yeah, like memantine. Yeah. Yes, thinking about those ones. Corazon antibodies or monoclonal antibodies. Yeah. So we can start with let's start with the cholinesterase inhibitors. Shafia stored as an example is donepezil. We also have galantamine. We have the likes of rivastigmine. So what are the mode of action of these cholinesterase inhibitors? Sorry? So cholinesterase inhibitors, what do they do? Yeah, so they will inhibit the degradation of acetylcholine, hence you'll have more acetylcholine. And ideally, this will improve the symptoms because we talked about the acetylcholinergic cholinergic being implicated in this disease, like as one of the causes of. Okay. Yeah, it is. And also remember these cholinesterase inhibitors, they are the first line or the gold standard for management of Alzheimer's. Is that okay? Okay, so what are some of the side effects of these cholinesterase inhibitors? Corazon is also telling us they do not stop the neurodegenerative process. I think they just slow it down, Mama. Yeah. Tacrine will cause hepatotoxicity. Can you remind us what which class of tacrine or which class tacrine was in? Oh, it's a acetylcholine esterase inhibitor. Oh, thank you. So you have that drug tacrine as a type of cholinesterase inhibitor. In addition to the donazepam, rivastigmine, and the galantamine. Any side effects someone knows about that we should maybe tell the patient or look out for? Okay, so let's move to the other class of drugs, the NMDA receptor antagonists. The example is the memantine. What's the mode of action of memantine?
It's a competitive agonist of NMDA. So it block the NMDA receptor. So it will inhibit the excessive release of glutamate that may lead to worsening of Alzheimer's.
Alzheimer's. Yeah, you said it's a competitive. It's a competitive antagonist.
Non-competitive.
Yeah, it's an non-competitive antagonist of the NMDA type receptor for glutamate. Any side effects for memantine that we should know? Okay. So the other class is the other class of drugs. Should we talk about the monoclonal antibodies? I think they're not really used as much. Talking of constipation,
So if I'm explain a bit on the NMDA receptor.
Okay, thank you.
So glutaminergic overexcitation usually results in neuronal damage, and that's why we use this antagonist in the Alzheimer's. Then the binding of this drug to the NMDA receptor is voltage dependent, and it interacts with the magnesium binding site of the channel, not to prevent that excessive excitation.
Thank you. So anything else that can be added for this Alzheimer's disease? Any mode of action we have not covered well? Any side effect? Any major side effect we need to know about? Literally anything that I've missed out on, or rather that has not been mentioned that you feel it's critical to know for the exam. So if there is nothing else, I don't know if we should stop there, or I don't know, we can do some past papers, I'm not sure.
Salad. The C in carrot stands for COMT inhibitors. The salad sasa, S is selagine, A is anticholinergics, L is dopamine, A is amantadine, the D is dopamine agonists. I'll share this in the group.
Okay, thank you. Okay, if there's nothing else, thank you for listening. If you want to continue with past papers.
Yeah, so a quick question is, for the Parkinson's drug, especially for the decarboxylase enzyme inhibitors, in what situations do we choose benserazide over carbidopa? In what situation do we choose benserazide over carbidopa? Anyone with an idea? In what situation will we choose benserazide over carbidopa?
I think it depends on the type of the formulation of medication you're using. But they're both used in combination with levodopa. And then effective in the same way. So I think there's one time where carbidopa will be more effective than benserazide, and the other way, vice versa.
So anyone else with an opinion on why we prefer benserazide over carbidopa? Or in what situation would we choose benserazide over carbidopa? Just by a quick search is just saying that the levodopa benserazide combo might be a better choice for patients who are experiencing more severe adverse effects or have an inadequate levodopa efficacy. And the levodopa carbidopa is more useful in patients with motor complications. So the benserazide here is saying that for patients with more severe adverse effects, you prefer benserazide, but with motor complications, you prefer carbidopa. As a research paper on the difference between the two. So moving on to HIV, human immunodeficiency virus. If I break, kindly just inform me. I don't know what to do about my internet. Yeah, so human immunodeficiency virus. What do you know about HIV? I'm sure you must know something about HIV. People who went to Madare CCC clinic they are HIV experts. So yeah, something about HIV that you may know, anything. It may be what it stands for, the stages of HIV, the drugs used to treat HIV, anything that you know about HIV. The chat box. Stanley is saying HIV is a retrovirus. HIV is a retrovirus. Someone else? HIV. Hey, I'm sure you guys know a lot on HIV. Yeah, HIV patients can get TB and oral rash. Yeah, because of that immunodeficiency. Yeah, anything else? Anything, even on treatment. Anything you know on HIV. Can be transmitted sexually. Yeah, it's the virus. It's the virus that causes AIDS. Remember, HIV is just a virus. AIDS is a syndrome, acquired immunodeficiency syndrome. Yeah. Something else about HIV, that it can also be passed from mother to baby. Yeah, that's true. HIV/AIDS has 4 stages. You guys have been studying HIV since class 4, I think. Yeah, there are 2 types, HIV-1 and HIV-2. Endeleeni, yeah. Jambi, basics za class 4. Aya, ongeza na your pharmacy education. What have you learned about HIV in your 5 years? What have you learned about HIV?
HIV infects the CD4 T cells, and then it uses its transcriptase to transcript the RNA genome, and which is also integrated into the host cell genome.
Yeah, it primarily infects the CD4, yeah, and then it will be integrated into the host cell genome. Dr. Sonia is saying that the common regimen is lamivudine, dolutegravir, and tenofovir. That's the first line regimen, yeah, to patients with HIV. Anyone else with something to add? I can see something here. Treatment, we can give the NRTIs, which block the enzyme reverse transcriptase. An example is lamivudine. Guys are mentioning treatment, you are not mentioning prevention. And NRTIs are only effective against HIV type 1. The viral load will be used as a marker for effectiveness of treatment. as a way of prevention or protection, you can use the barrier methods of contraceptives. There's anyone else? Someone with a burning issue? I don't want to lock anyone out before we start. I'll wait. I'm seeing there's an image that has been sent. So you can important HIV symptoms, yeah. So those ones have also been sent on the chat box. Kindly also share them on the WhatsApp group. Someone please enlighten us on PrEP and PEP. Yeah, we'll be covering that. PrEP and PEP. We'll be covering that. Just yeah, I think now we can start. So let me see if there's a document here. Yeah, so I'll be using our data, Kenyan data, and this data is based on 2022. Or rather, this document was printed or drafted on just last year March. So this data is really recent. This is now the epidemiology of HIV in Kenya in 2021. We can see that 42% of the new infections are majorly occurring among the youth between 15 to 24 years. So currently in Kenya, 15, the people between the ages of 15 to 24 are among them. These are the 15 to 24 years, late adolescents or adolescents to young adulthood, 15 to 24 years. Yeah, 42%. I think that is very alarming. That is very alarming, and hence the need for some preventative tactics that some informed cabinet secretaries may be proposing. Otherwise, you can see, in short, currently the new infections are occurring among not even the youth. When you say the youth, within 20s to 30s, you can see it's between 15 to 24 years. This is between high school and just finishing campus. Somewhere between that age, there's a lot of new HIV infection in our country. And according to, you can see Homa Bay, Kisumu, Siaya, Migori, right? The Nyanza region, that is according, before the new constitution, that was all the Nyanza province there, right? There is where we can see a lot of the infections of HIV. And then also you can see Busia is still there, Kisii. These are one of the most implicated places. Mombasa. I think for these areas, for the Nyanza region, they did a study and they saw that mostly it's because of they trade for fish for sex, right? That the fishermen will go fish and then trade the fish for sex. Then in Mombasa, majorly due to the tourism. Nairobi, we say it's the headquarters. Uasin Gishu, that is the great people of Eldoret, Kina COH, you need to do some sensitization. In Uasin Gishu, Vihiga also. Nakuru here, it's an error. I saw that in the new document, Nakuru is just an error. The prevalence of HIV in Nakuru is I think 0%. It's the safest county so far. No infections of HIV. So all of you thinking of going to Nakuru, that's the right decision. I'm seeing Black Panther or in issue, please, your prevalence is false. Anyway, that's the prevalence. So if a question is asked majorly right now, it's among 15 to 24 years. That's where we are seeing prevalence of HIV among the 15 to 24 years. And so now we'll go a bit to the science, then just come back to this document for treatment, because it really summarizes the treatment of HIV. Yeah. So going to the science part. Not even here. Yeah, here. Light infecting this CD4 cell, right? And even from here, we'll be reminded of the stages, or rather the life cycle of a virus generally. We say a virus will attach, it will enter, it will release its nucleic acid, its DNA material, that is. New proteins will be synthesized, and then the virus will leave. It will assemble just outside the cell in the plasma membrane, and then bud out, right? And for HIV, it's the same thing. It's the same thing. HIV, first of all, it will bind to a receptor, right? Binding will cause fusion with the plasma membrane. When it fuses, it will release its genetic material. Its genetic material in this case is HIV is an RNA virus. That genetic material will be integrated into the DNA. Then the proteins will be synthesized. So the new virus, or the new virion particle, will assemble just near the plasma membrane. It will assemble, and then it will bud out and go in and infect other cells. So that is the general life cycle of HIV, like any other virus. Binding, attachment, fusion, releasing of its content, replication, and then it goes out to conquer new grounds, right? Now, something unique about HIV, and that is why we will refer to it as a retrovirus. It's because it releases its RNA, then the RNA is transcribed back to DNA, right? It's transcribed, that is retro, because we know information should flow, or information flows from DNA to RNA to proteins. But here we are having RNA back to DNA, that is retro, we are going back. So it will reverse transcribe the RNA to DNA. The DNA is now this one in red. Then the DNA will be integrated into the host DNA. Then after it's integrated into the host DNA, again, transcription will occur. Then translation of the now viral proteins will be done, and then we'll have a new virus getting out to conquer new CD4 cells. So that is why, that is something unique with HIV, that it will move from an RNA into a DNA. That is retro, right? Yeah, it will be going back. So that's the general. But something to remember here is, number one, the reverse transcriptase, that there is a reverse transcription here because there are drugs that will target here. And then the integration. There is an enzyme called the integrase, which integrates the HIV DNA to your host DNA. So that's also another target of the drug. Of course, another target of the drug will be entry, right? If we inhibit this entry, it means all of this doesn't happen in the first place. Yeah. So now let's go to a bit more, not complex, but now what is more testable. So this is, again, this is a CD4 cell. This is a CD4 cell, right? This is a CD4 cell. So here we have HIV. HIV has come through its GP120, through that protein, it binds to the CD4 receptor. And you can see these co-receptors here. And we always say with HIV, the co-receptors are essential also for infection. The co-receptors are essential for entry of the virus into the cell. And the study that was done, I don't remember when, perhaps Stanley can say, the study that was done among some sex workers in Nairobi who cannot get HIV, they were found to that they do not possess this one of these co-receptors. And if you don't possess one of these if you don't possess this co-receptor generally, that virus can't enter your cell, meaning you can't get HIV. It was a small study. I know perhaps right now they are doing more studies to see, but generally the co-receptors, they are critical for infection. So you can see the GP120 has come, it has bind to the CD4 receptor. And then that binding is also facilitated by also this co-receptor. You can see it was here, but now the co-receptors have also been involved to enhance this binding. Once this binding has taken place, now we can have the fusion. Remember the previous diagram, I'll just be switching between the two. Now that binding has occurred, right? Now we're in the stage of fusion. Now we can have fusion. Fusion will occur between this nucleocapsid membrane and the plasma membrane. Essentially, that fusion will cause the stuff inside the nucleocapsid to be released. What is the stuff inside the nucleocapsid? We have the HIV RNA, already said the RNA. We have the reverse transcriptase that we'll see we will want to inhibit. We have the integrase that we'll see we will also want to inhibit, and other viral proteins. But the most significant, the ones you shouldn't forget, the RNA, the reverse transcriptase, and the integrase. So those components, they are now released into the cytoplasm. They've now been released into the cytoplasm. Now, the first step, again, is to take you back here. Once this stuff has been released, what we first do to our HIV virus is reverse transcription. What we first do to our HIV virus is reverse transcription. And that is what is happening here. The viral DNA is formed by reverse transcription. You can see here where you have your viral RNA, where you have your reverse transcriptase enzyme. From your reverse transcriptase enzyme, you get your viral DNA. Then the viral DNA will be transported across the nucleus and will be integrated into the host's DNA, right? It's what Shafi said, that the viral DNA will be transported across the nucleus and be integrated into the host DNA. What enzyme will do this? Now we have the integrase enzyme, integrase enzyme. So now your DNA has the HIV DNA, the viral DNA in it. Now that your HIV has the DNA, now that your DNA has the HIV DNA in it, now we move to the next step. Here, just to take you back to genetics, what will happen? It will be transcribed. Transcription will yield our RNA, our messenger RNA. From our messenger RNA, what will we do? Our messenger RNA, the RNA will be translated. Yeah, the RNA will be translated here by the ribosome to make the viral proteins, right? And remember also another thing to recall from transcription, DNA to RNA, also there will be a lot of transcription so that also you are able to produce just copies of RNA that will be incorporated into the new virus. The copies of the RNA that will just be incorporated into the new virus, right? So in short, now you have your viral proteins and you have your RNA, right? You have your viral proteins and you have your RNA. Now they assemble here at the plasma membrane saying, yeah, getting ready, saying, we are now ready to infect the new cells, yeah? Remember you guys on October 13th sending videos, get ready for graduation. Now this Nini is saying that get ready to infect new cells, you know? That's the joy of HIV. So the viral RNA and the proteins, they have moved here at the cell surface, they are assembling. Stano is here. RNA iko wapi? RNA is here. Reverse transcriptase iko wapi? They are saying, bado reverse transcriptase haijamachua vizuri, haijamachua, it's right. Mbona haijamachua? Because now we get to the last enzyme, or rather to the last significant enzyme that we'll mention in this discussion, that the virus will mature when the protease releases the proteins that form the mature HIV. So here what we're talking about is that the RNA has been translated in the ribosome. The RNA has been translated in the ribosome into a polypeptide. Remember what we said about polypeptide, right? In that polypeptide, remember if we cut a polypeptide, we can cut one portion. From that one portion, we obtain our reverse transcriptase. If we cut another portion, we obtain our integrase enzyme and all other functional proteins, okay? So from the ribosome, we get a polypeptide that is, in short, it is all of these proteins have been put together into like one polypeptide. And as such, they are inactive because they are just one long polypeptide. And that is where this protease enzyme comes in. The protease will come and now cleave the polypeptide into the functional parts. It will cleave the polypeptide into the functional parts. We'll now get our reverse transcriptase by its own, our integrase by its own, and other viral proteins ready now to attack. And now when the virus says, nice, everything iko chonjo, nasema everything iko chonjo, now the virus, we can now call it a mature virion. It gets out ready to restart, ready to begin again the process of infecting another CD4 cell, and the process goes on and on and on. So based on that, the pathophysiology, I feel like it's everything. Once you understand the pathophysiology here, the drugs you just mentioned now. Now, for drugs, we will have reverse transcriptase inhibitors, we will have the integrase inhibitors, and we'll have the protease inhibitors, right? The other class that we'll also have is the fusion inhibitors, okay? Just, it's based on the pathophysiology. If you understand the pathophysiology, just saying a reverse transcriptase inhibitor is enough because you know what the reverse transcriptase does. So if you come and inhibit here, it means the viral RNA is never turned into DNA, it's never integrated into the host, hence there's no replication. If you inhibit integrase, there's no replication that will occur. If you inhibit protease, no new virions will be formed to infect other cells. See, kindly repeat step 6 and 7, okay? Comfort, can see you've raised your hand.
Yeah, I was asking to repeat from how do we move from the immature virion to the mature one?
Okay. So let's just go back to here. We remember in let me take you back to something that perhaps I hope you'll correlate the two. Insulin. When insulin is synthesized, when we have that flow of information from DNA to RNA to proteins, right? We have the insulin gene that will be transcribed and we'll get our messenger RNA. The messenger RNA will go to the ribosome and it will synthesize, or rather it will be translated to produce, let me call it a hormone. That hormone is not usually insulin, it's pro-insulin. Like it means it still needs some activation, it still needs some action to be insulin, right? Pro-insulin, it can't do anything on the sugar level, but insulin, that is what does the magic. So the body, just working from the body does synthesize proteins in an inactive form that can now be cleaved to an active form later when it's needed, okay? And this is what we are talking about here, that the RNA, the HIV RNA will go to the ribosome, it will be translated, and we will have this long polypeptide, right? This long polypeptide that literally cannot function, right? That long polypeptide, let me annotate. I don't know my yeah. So this is what will leave the ribosome. An example, right? We are having just one long polypeptide. And in this long polypeptide, somewhere in that polypeptide is where we have the reverse transcriptase. Write it as RT. Somewhere in that long polypeptide, we also have our integrase, just write it as capital I. Yeah, and somewhere in that reverse transcriptase is where we have our other, let me just call them other viral proteins that are necessary. Remember, HIV has a lot of proteins, but these are the ones that are significant: reverse transcriptase and integrase. So this is what leaves the ribosome, just one long polypeptide. But in this form, reverse transcriptase can't function because it's been attached to other things that are not helpful, right? Or rather that hinder it from functioning as it should. And now at this stage, this is here. This is at this stage where we now call this an immature, like here it is in an immature stage, right? Or it's an immature virion. Why is it immature? Because it can't infect any other new cells, right? It's immature. It means it still needs to mature further. It still needs to grow a bit more, right? And this is where the enzyme protease comes in. Protease, just from the name, it means it's breaking down a protein. This is now the protein. Protease comes here and gets to work. It starts cleaving. When it cleaves, reverse transcriptase now it's on its own. The integrase now it's on its own, and now these enzymes can function. Hence, now we can say now this here is a mature virion. Or rather, no, now this virus here, it's ready to infect other cells. Have we understood?
Yeah.
Stanley? Haya poa. Yeah. So yeah, so that's it. So that's the pathophysiology. And now I believe we can just go to the drugs real quick. Or rather, before going to the drugs, someone mentioned symptoms of HIV. Symptoms of HIV. Now, typically, HIV has no symptoms. Typically, like we don't say there are symptoms of HIV when you get infected. Let me say acutely, right? When you get infected. However, there are actually symptoms. There are actually symptoms of HIV. And this these symptoms, they are like symptoms of a common cold, right? You get like symptoms of a common cold. No, wait, it is. Yeah, here it is. Just let me just highlight this part. Patients who are newly infected with HIV may be asymptomatic or maybe present with non-specific flu-like symptoms like fever, myalgia, arthralgia, lymphadenopathy, pharyngitis, and rash. This stage is known as the acute HIV. So in this, I guess here it's more of advice to you, because you can't say every patient that comes to you with a flu you have to test for HIV or you have to ask. But this is more as an advice to you, that if you suspect you've been exposed to HIV and then you get a flu, get tested. Get tested, or start PrEP, whatever, if you're within the hours, right? So if someone suspects they've been exposed to HIV and then somehow they get a flu, you know that it increases your suspicion that this person may actually have or may have been exposed to HIV. Remember, as pharmacists, we are empirical healthcare workers. Us, we don't rely on lab tests or anything. We're the tough guys. So we need to know such things, right? That someone suspects they've been exposed to HIV, they come presenting with a flu a few days later after they suspect they've been exposed. Just tell them after like 2-3 weeks, let them come and get tested. So that's it on symptoms. Then real quick, oh no, that's not it on symptoms, I'm sorry. So the other symptoms, as Jambi said, there are the 4 stages of HIV, right? Stage 1, stage 2, stage 3, stage 4. Or if you want to go the old way, what was the old way? Window, incubation, symptomatic, and AIDS. Yeah, window, incubation, symptomatic, and AIDS. But now we are pharmacists. We can't be saying the same thing as what we used to say in class 4, right? So in the first stage, it's the window stage, right? It's the window stage where we say there'll be asymptomatic. Both adults and children, they'll be asymptomatic. No, nothing bad. No symptoms at this time. There may be some persistent lymphadenopathy, but generally asymptomatic. Then in stage 2 of HIV, you see this person, there's some weight loss. They keep getting some sore throats. They keep getting some ear infection. The herpes zoster comes in, you know, they're saying half my back. There are some rashes, angular cheilitis, right? Recurrent oral ulceration, some fungal nail infections. Here we have the onychomycosis, we have seborrheic dermatitis, you know, some fungal infections coming in, some superficial fungal infections there, some upper respiratory infections keep being repeated. Then we say this person is in stage 2 of HIV. Then in stage 3 now, there's more weight loss. This person is having diarrhea. There is where the pulmonary tuberculosis kicks in. We're having pulmonary tuberculosis. Bacterial infections, they are becoming more severe, stuff like pneumonia, stuff like meningitis, right? Also anemia, neutropenia. Yeah, this person is now just, they are mostly sick, right? Oral candidiasis. Then finally in stage 4, this is where we are having the HIV wasting syndrome. If someone, I don't know if you ever get a chance to go to KNH and you're taken to, I don't remember the name of that wing, to the there's a specific wing for the kind of HIV patients, especially at stage 4. The AIDS patients, it's sad, but those patients usually they're usually in the bed. It's like they've disappeared. If you don't look closely, you won't see as if there is someone. And that is the HIV wasting syndrome. Someone is depleted completely. You can barely see the person. It's just bones. You have PJP comes in, extrapulmonary TB. So remember, in stage 3, we are having just pulmonary TB. We are having here stage 4 extrapulmonary TB. Here is where we'll even have toxoplasmosis, cryptococcal meningitis. So if you hear a patient is having such symptoms, know that they are in a very severe stage of HIV. Even stuff like leishmaniasis can come in, HIV encephalopathy, esophageal candidiasis. Yeah, I'll share this document for you to just have a review. Yeah. So chronic, the herpes simplex infection now is just chronic. It's not having that disappearing pattern, stuff like that. Okay. So those are the symptoms of HIV, or the stages of HIV infection. And also something to know here in the stage 4 is where you'll even see the cancers can come in. Remember, we say HIV is a risk factor to any type of cancer, because the immunity of the body is involved in fighting off cancer. So you can see here the lymphomas, Kaposi's sarcomas, cervical cancer. This is where they are really coming in a big way, yeah, to bring about, to be more invasive, so the prognosis will end up not being that good. So finally, we'll go to management. And for management, the good thing is that Sonia already summarized the management for us. First line management will consist of that tenofovir, lamivudine, and dolutegravir. So quickly, again, I'm asking for active engagement here. Just what are the classes of anti-HIV medications? The classes and the associated side effects. Classes of anti-HIV many classes of antiretrovirals. I think we've already looked at them when we were mentioning here the life cycle. So
reverse transcriptase inhibitors. Reverse transcriptase. There are two types.
Reverse transcriptase.
There are two classifications of reverse transcriptase: the nucleoside and non-nucleoside. Nucleoside examples are zinovudine, lamivudine. The other ones are,
and the non-nucleoside,
nevirapamine.
Nevirapine, yeah, and efavirenz, right? Another class, so she's told us about the reverse transcriptase inhibitors, the two classes, the nucleoside stroke tide and the non-nucleoside. Scooby-Doo, as mentioned in the fusion inhibitors. You can also tell us an example of a fusion inhibitor. Felicia, protease inhibitors. What are examples of protease inhibitors? Yeah. But okay, let me see. For the sake of time, maybe I'll just cover them here real quick in a table. So starting with the nucleoside stroke tide reverse transcriptase inhibitors. Here, majorly, we have our, we'll mention, I think, this 1, 2, 3, 4. The first 4. The other ones, I'll leave them for you. Abacavir, emtricitabine, lamivudine, and tenofovir. So for abacavir, something that should be noted with abacavir is that there's that hypersensitivity reaction that can occur with abacavir. So with abacavir, there's that hypersensitivity reaction that can occur. So that should be watched out for. If it does occur, stop abacavir. That's the side effect to be remembered. Hypersensitivity reaction with abacavir. Going to emtricitabine and lamivudine, those ones, nothing much in terms of adverse drug effects. Nothing much in terms of adverse drug effects. I think Scooby-Doo has added that integrase inhibitors, we have the mighty dolutegravir. Yeah. So emtricitabine, lamivudine, nothing much. Then tenofovir, we mentioned especially one thing, or rather two things. Number one is the renal insufficiency that can occur, renal insufficiency. And number two, decreased bone mineral density. Renal insufficiency and decreased bone mineral density. So remember, as Dr. Amsal always used to say, if a patient is having CKD, it reaches a point you have to stop the tenofovir, or rather stop and substitute it with abacavir. Remember, abacavir is safe. No issues with the renal, but tenofovir, if a patient is having renal dysfunction, stop it and substitute it with abacavir. Yeah. Then they can continue the lamivudine and the dolutegravir. Those ones they can continue. Moving on to the non-nucleoside reverse transcriptase inhibitors. Here, again, we look at the two major ones, nevirapine and efavirenz. Nevirapine, here, the side effects to remember, number one is the rash, including the possibility of causing Stevens-Johnson syndrome and an aspect of hepatitis. Okay, it has some aspect of hepatotoxicity. That is nevirapine, right? The thing now is efavirenz. Efavirenz, I think we'll remember efavirenz with nightmares, right? Efavirenz, nightmares. Which anti-HIV is known to cause nightmares? Efavirenz, you know, they ever ask you that. Efavirenz, nightmares, and also it also has the potential to cause a rash. It also has the potential to cause a rash. Moving on to the protease inhibitors. Protease inhibitors as a class in a whole, the major thing that we mention with protease inhibitors are the metabolic abnormalities or metabolic disturbances. Protease inhibitors will raise the glucose levels, as we mentioned in diabetes. They will raise the lipid levels, right? They will raise the lipid levels. We'll see also an aspect of weight gain in the patient. Remember previously HIV patients, they say you could recognize them by how malnourished they are. These days, yeah, there's really this antiretrovirals that cause the weight gain. For those of you that are interested in veterinary regulation, these are the stuff that are used as they are given to the chicken so that they can fatten up real quick, the protease inhibitors. Okay, so the next time you're in chicken in, remember my voice. Protease inhibitors has been given to. Let me not say that. I'll delete that part. I don't want to be sued. Lastly, not lastly, fusion inhibitors, as Scooby-Doo mentioned. The fusion inhibitors, they just inhibit that fusion, but that one is a subcutaneous injection. All the other ones are oral. That's why this enfuvitide is a subcutaneous injection, once in the morning and once in the evening. Of course, with an injection, you expect there'll be some pain or erythema in the injection site, right? But these fusion inhibitors, and even these CCR5 antagonists, mostly they say that they are mostly reserved for research uses. They are rarely used, but you should just know at least the example. The fusion inhibitors, the enfuvitide, and the CCR5 inhibitor or antagonist is maraviro. Finally, we finish with dolutegravir. Dolutegravir, something you should never forget is the insomnia it causes. For this reason, you'll tell the patient to take it in the morning, asubuhi na mapema, yeah, so that they don't get insomnia at night. Then also the other thing that we know, HIV and TB easily coexist, or rather they can be co-infected. So when you're giving the patient that first line regimen, tenofovir, lamivudine, dolutegravir, you'll need to double the dose of dolutegravir due to that inductive action of rifampicin. Perhaps one thing I didn't mention with protease inhibitors is that they are given with this ritonavir, which is, remember, I think we've discussed it before. It's a pharmacokinetic enhancer. It inhibits the metabolism, or rather the breakdown of these protease inhibitors. So if it inhibits that, we are able to prolong the action of our drugs. So that is it on ARVs. Yeah, let me see on the chat box. So if a patient is infected with both TB and HIV, actively infected, we have to give both the HIV regimen and the TB regimen, and assuming we are giving the first line, tenofovir, lamivudine, and dolutegravir, and you're also giving the RHZE, you'll need to double the dose of dolutegravir because of the inductive action of rifampicin, right? Rifampicin will induce the metabolism of dolutegravir, essentially making it have a shorter duration of action. Hence, we give one in the morning, one in the evening. Right, 50 mg in the morning. The 50 mg will be in the combined tablet. Remember, TLD, it comes in a combined form. So the patient will take the combined in the morning and then dolutegravir alone in the evening. Yeah. The other thing that we give for HIV, we know cotrimoxazole or Septrin, the combination of sulfamethoxazole and
Able to repeat why you increase the dose for the dolutegravir?
So, see, we've covered before that rifampicin is a potent CYP inducer. So if the patient is taking both rifampicin and the anti-HIV regimen, you'll need to double the dose of the dolutegravir, because in metabolism of dolutegravir will be induced. Yeah.
Okay.
Then for that one, it's with Black Panther, it's with rifampicin. If you've switched to rifabutin, I think it's they can just continue with just the combined tablet on its own. It's with rifampicin specifically, that first line regimen for TB. So cotrimoxazole, we've mentioned, I think it's been mentioned a million times before. It's used to prevent opportunistic infections, the likes of PJP, right? And even toxoplasmosis, it does act there. So that's just as an add-on to the treatment. Again, you'll see all HIV positive women between those agents should be screened for cervical cancer. As we mentioned, HIV will decrease the HIV affects immunity, essentially, increasing the risk of cancer. Then recently, finally, the Kenyan government has introduced the narrative undetectable is equals to untransmittable. So if a patient is taking their HIV very well, their HIV, anti-HIV, antiretroviral, their ARVs very well. They're taking their ARVs very well, and you can't detect when you do the test, you can't detect HIV in their bloodstream. It means they can't also transmit it. Okay, so that can be a counseling point even to your patients. You encourage them that if it gets to the point it's not detectable, they can't transmit it even to their partners. So undetectable is equals to untransmittable, but again encourage them, they still need to keep taking the HIV drugs so as to continue being undetectable. So here is just a summary of, or rather, just as a revision for what we've covered. You can see for 30 kg and above, I'll just start at the bottom, is what we've mentioned there. Tenofovir, lamivudine, dolutegravir. Then below the 30 kg, here you can see we mostly will give the abacavir and lamivudine, that combo, abacavir and lamivudine. And because these people, or rather at the following weight, mostly we may find that they are children. You see, we give the dispersible tablet formulation. But between birth to 4 weeks, we give the AZT, that's zidovudine, lamivudine, and nevirapine. Zidovudine, lamivudine, and nevirapine. So again, just give me 10 minutes, I'll be done. I know you want us to go to KINAPEP. All of those are significant. Prevention of mother-to-child transmission. Yeah. So generally for adults, just know for adults, generally it's this tenofovir, lamivudine, and dolutegravir. This is what we give to adults. Okay. Then something we need to mention, I've also seen it here on the guidelines. Here, this is what we already mentioned. If a patient is on rifampicin, we will double the dose. So they will take the combination in the morning, and then in the evening, AM, remember AM, morning, PM, evening, we did this under prescriptions, right? They'll take the 50 mg in the evening, and after the TB treatment has been stopped, they'll continue that for an additional 2 weeks, because we know that inductive action does not just stop immediately you stop rifampicin, right? It will proceed for a bit longer. That is what we've said. Then here, for patients who are co-infected with hepatitis B, which are many patients with HIV, you find that they also, most of them having hep B. You want to give them drugs that are also active against hep B. What are those drugs? Tenofovir and lamivudine, right? You want in their regimen, at least you want one of those to be there, if not both of them. If the patient has good renal function, give both. If the patient has poor renal function, maintain the lamivudine. You can substitute the tenofovir for abacavir. So, moving on, I think, yeah, now we'll go to prevention, PEP, PrEP, and prevention of mother-to-child transmission. Prevention of mother-to-child transmission. How will you advise the expectant mother so that they do not infect their child with HIV? So first of all, the mother needs to be taking her ARVs. Throughout the pregnancy, she needs to be faithful to she needs to be adherent. She needs to take the drugs faithfully, right? So that she can make sure her viral load is as low as possible, right? Then at birth, the infant will be born, right? When the infant is born, right? When the infant is born, you will start the infant on the zidovudine plus nevirapine for 6 weeks. When the child is born, you'll give them zidovudine and nevirapine for 6 weeks. For those of you who have been in a CCC clinic, you'll notice that these drugs also come in an oral solution form. Yeah, in a solution form. Zidovudine and nevirapine for 6 weeks. Then after the 6 weeks, you'll stop zidovudine. After the 6 weeks, you'll stop zidovudine, and you'll continue nevirapine for as long as the child is being breastfed. And after the mother stops breastfeeding, you'll continue it until 6 weeks after that. So if the mother breastfeeds up to 2 years, you will continue with nevirapine until the child is 2 years and 6 weeks. If the mother stops at 6 months, you'll continue until the child is 6 months and 6 weeks. Okay? So, but the but the zidovudine, you will stop it just after 6 weeks. Remember, zidovudine has a bone marrow suppression activity, and this child is growing, right? And it also has a metabolic affecting the mitochondria. So it's associated with more adverse effects. We don't want to give the child a lot of zidovudine, but nevirapine just a bit safe. I know we mentioned some bits of hepatotoxicity, but of course you'll be monitoring for that, right? So prevention of mother to child, the mother needs to be faithful to her ARVs throughout pregnancy, throughout breastfeeding. When the child is born, this combo for 6 weeks, stop the zidovudine, continue nevirapine for as long as they are breastfeeding, and then 6 weeks after, the mother stops breastfeeding, right? Then on this note, if the mother is not breastfeeding, you will stop the nini at 6 weeks, the combo at 6 weeks, and continue the nevirapine for another 6 weeks, so that they'll be on 12 weeks, right? Then we know, I think this one is mentioned, that all infants should be breastfed for the first 6 months of life, right? After the first 6 months is when we start introducing food. Generally, the recommendation is they should be breastfed for up to 2 years, but after 6 months, or rather, but after 1 year, there's some references say it's not, but you can stop it at that. Moving on to PEP, PrEP and PEP. Yeah, now let's go to PEP. PEP, post-exposure prophylaxis. Who can tell us about PEP? I know you guys are PEP experts. Don't want to mention names. PEP. How do we give PEP? In what's the window of PEP? Post-exposure prophylaxis. Remember, even you as a healthcare worker, you may find yourself taking PEP due to even needle pricks and such things. PEP. How do we give PEP? Chat box, I'm saying, within the first 72 hours of possible exposure. We need to give PEP within the first 72 hours of possible exposure. Remember the principle of PEP and also the principle of PrEP. It's that the drugs will inhibit the replication of the virus such that the little virus that will have replicated, the body can fight it off. The little virus that will have replicated, the body can fight it off. That's the principle of giving PrEP. That's the principle of giving PEP. That the little virus that will have replicated within these first 72 hours, the body can adequately fight it off, right? But after the first 72 hours, now we just wait and test for HIV. Now it's based on your luck. Now for PEP, again, for PEP, we just give the same regimen. We know in Kenya, the issue is availability. Today you go and find it's this ARV that is there. The other day it's this one. So we can still give the first line regimen to be taken every day for 28 days, right? Within the first 72 hours. They need to start within the first 72 hours. Then they'll take 1 tablet once a day for 28 days. Again, here you need to emphasize on adherence. You need to emphasize on them being faithful to their ARV regimen, and also them not risking any other exposure. Right? They may be thinking they're on PEP, but they can't get infected. They can end up getting infected on the 21st day through unprotected sex. then you've stopped it on the 28th day, and then the HIV starts replicating. So you need to really advise appropriately. So you can either give that first line regimen, tenofovir, lamivudine, dolutegravir, or you can substitute the lamivudine for emtricitabine, right? You can substitute the lamivudine for emtricitabine. Next, going to PrEP. PrEP. So for PrEP, how is PrEP taken? PrEP. No, post-exposure, this is after possible exposure. Pre-exposure, this is these are people who perhaps their line of work, perhaps the sex workers, right? Someone is taking PrEP so as to make sure they do not contract the virus. How will you advise them? And what drugs will you give for PrEP? It's literally right there. You can just read out. So for PrEP, again, it's the same, kind of the same drugs. Again, I'll mention in Kenya, because of availability issues, you can find even the patient taking PrEP is still taking the 3 drugs, tenofovir, lamivudine, and dolutegravir. However, as per the guidelines, it's just 2 drugs that are recommended for PrEP. That means like a combination of just 2 drugs. You don't need 3 drugs when it's PrEP. We give just tenofovir and emtricitabine. Or sometimes you'll see they give tenofovir and lamivudine, right? Just as once daily. That is PrEP, pre-exposure prophylaxis. And then we have individuals who they just want to take PrEP because they anticipate a risky sexual encounter. And here, majorly, we are talking about the MSM. I believe we all know what MSM means. And for MSM, where it's called event-driven or anticipatory, you'll see you'll tell them to take 2 pills between 2 and 24 hours before intercourse, then a 3rd pill after 24 hours. And then a 4th pill after 48. In short, the 2-1 principles. 2 pills, you can say 24 hours before, 1 pill 24 hours after, 1 pill 48 hours after the first 2 pills or after 24 hours. Yeah, that is event-driven. And then for our ladies, thanks to technology, there is now this the PV ring, right? Which is a vaginal ring. It's inserted vaginally, and you use it it can be used for 28 days. It protects you against HIV infection. So that's PrEP, covered. Prevention of mother to child. Yeah, unless someone has something to add on HIV, mimi ninasema asante for prolonging the discussion. Karibu. Half-life ya PEP na PrEP. Okay, I don't know about the half-life. I don't know about the half-life in terms of hours or that, but for just what I know is the guidelines for PrEP is just those 28 days within the first 72 hours. But for PrEP, the general advice that is applied in the healthcare settings is that after, for example, let's say this person, let's say it's a sex worker in this case, for this type of, for example, if they stop the job today, waseme after today, I'm no longer engaging in dangerous or risky sexual encounters. Yeah, they are usually told to continue that PrEP for 7 more days, and then it's stopped. So I can't talk about the half-life at the specific, but for PrEP, after your risky sexual encounters, if you know you are done, you advise just continue it for 7 more days, and then you can stop it. That is for PrEP. For PrEP is just those 28 days.
There was kulikuwa na a case where someone was taking PrEP and the person alianza for like the first 2 days and then skipped for like 4 days. So what would you advise that person? Aendelee ama awache juu after 4 days? Yes, that's a long time.
That's a long time, but given alikuwa ashaanza, in such situations hakunanga ati a specific, but given alikuwa ashaanza, you can give them for 20, like after ameskip those 4 days, umuongezea an tablet zingine ikuwe nikaa ameanza day 1 tena, aende 28 days. Then according to the guidelines is after someone has stopped PrEP. So Apple is just, it's them being lucky or being unlucky.
Okay. Thank you.
Yes, we're good. Tunaweza patana 5. Yeah, you know,